Roland, as you know, we are accumulating interviews with special people in the field of heart and lung transplantation and mechanical support who either at a moment in time or over their entire career have made unusual contributions to the field. And of course you are absolutely one of these people who have had a profound influence, not only in the country of Germany, but internationally in your contributions in these areas over the years. Tell us a little bit about your early days in terms of how you decided to become a heart surgeon.
Well, first of all, I thank you for your quite flattering statement. My career as a heart surgeon began when I moved to Hannover Medical School.
And that would be what year?
This was in 1971. Because I was interested in surgery, general surgery. And then, of course, in Hannover, I met a group of professors that were very young and very modern, like Borst, Pichelmeier, and Czerne, who were quite different from the previous, more patriarch-style department. And I got interested in thoracic and vascular, and of course cardiac surgery. That means I made a whole full training as a surgeon. And then, since I had passed this American exam for foreigners, I wanted to, let's say, use this and take the chance to go to America for a while for clinical work. And I then became a fellow of Frank Gabodi in San Francisco, who, as you know, was one of the old pioneers of cardiac surgery and still had a high reputation, and he had a program for foreign fellows. And I think it was a foreign fellow number 99. And during the time when I was in San Francisco, these 2 years, 76 and 77, I had the opportunity to meet the group in Stanford with Norman Shumway. And at that time, this was the only place in the world where heart transplantation was performed on a regular basis. That means whereas most of the earlier groups had given up this treatment, the Stanford group was the one that systematically studied this field. And as a matter of fact, I think until the early 1980s, when heart transplantation was spreading all over the world, the Stanford group had developed, I would say, 90% of all the insights and achievements and the knowledge about heart transplantation. And this, I think, was a key to the fact that results in Stanford then had become so good, and in particular after the introduction of cyclosporin A in 1980, which was also done in Stanford, into heart transplantation. There was let's say, a rapid interest all over the world. Other groups started it in America, Pittsburgh, or in London, Mark Jacob and Cambridge and so on. As a matter of fact, when I came back to Hannover in late 1977, we had made plans to start a heart transplant program there because Hannover Medical School was a well-known and very active transplant center for liver and kidney. So it seemed to be appropriate to start there.
They were not yet doing transplants in Hannover?
No Hannover, no heart transplants.
Were they doing transplants elsewhere in Germany at that point?
There had been 3 heart transplants in the early era, like in 69, 2 in Munich, 1 in Berlin, but they were given up. Why we couldn't start it in 1978 then was that at that time coronary artery bypass surgery was exploding, and the cardiac surgery units were not able to treat all those patients. So the cardiologist said, we don't want you to start a transplant program because this would further diminish your capacity for, let's say, conventional, in particular coronary artery bypass surgery. And it was not until 1981 when in Munich, the two groups, both in the heart, first in the heart center and then in Großhadern, as you know, Bruno Reichert, started heart transplantation, that sort of the pride of the Hannover group was sort of challenged. And then we decided to start a program. So in 1983, in July, I could do the first heart transplant in Hannover. And of course, this was a very young and enthusiastic team. And we did 72 heart transplants within 2 years, which at that time was an enormous number. Also with fairly good results, and I must say there are still some patients living from this early era, more than 26 years ago. So when I moved to Berlin to take over this newly set up Deutsches Herzzentrum Berlin.
And what year was that?
This was in 1986, exactly 25 years ago. As a matter of fact, in 5 days from now, 25 years ago, I did the first heart transplant in Berlin. Of course, we had the task to set up a large cardiac surgery center. And of course, heart transplantation had to be a significant part of it.
Now, when you took over in Berlin, and you were the chief at that time, there was a program existing in Berlin?
No transplant program.
But cardiac surgery,
yes, there was a cardiac surgery program.
For a person like yourself, who has tremendous expertise in a broad array of cardiac surgical operations, tell us about what part transplantation had in that landscape of your mind in cardiac surgery.
I think that's an important question, because from a surgeon standpoint, as you know, heart transplantation is not too demanding. It's more a question to understand this organ and to handle this organ properly. The surgical part is not too difficult. But of course, at the time, heart transplantation was such a fascinating tool, because it sort of gave the whole field of cardiac surgery an enormous boost, and also it raised questions that until then were not so important, like also ethics and brain death, organ retrieval, immunology, oncology. That means field that in the past for cardiac surgery were not so important. Suddenly it became a very stimulating aspect to do this heart transplantation and also to follow those patients. Because I must say in the beginning, cardiologists and internists were not so interested in it. Although I always said this pure gold in the street, scientifically and from an interest standpoint. So we had the chance, although this was in this political island, West Berlin, isolated, to not only set up a very large cardiac surgery unit, which was the biggest in the country, as a matter of fact, on the continent at that time, with 2,500 open heart operations, but also we could establish the largest heart transplant program. At the time also, I must say, we had much more organs available than nowadays. Like in 1991, we did 131 transplants which of course today we can only dream of. And then I had the opportunity to meet in Berlin my kind of predecessor, Professor Bücherl. Professor Bücherl was the head of the University Department of Surgery, which also did heart surgery at the time, just conventional cardiac surgery, which stopped when Bücherl retired in 1988. But the main thing was Bücherl had spent at least 15 years of his scientific work, in which he was very good, on the development of a total artificial heart, because he believed that such a artificial pump device would in the long run be more important and successful than transplantation. This was the idea at the time. That means when I came to Berlin, he said, well, you're just a transplanter. But this work of Bücherl offered the opportunity to use these pumps for all those patients that otherwise would die before a transplantation was feasible, for this concept of bridge to transplant. And in 1987, I used his total artificial heart for the first time as a bridge to transplantation in a patient. And this procedure was successful, which was the first in Germany. Bücherl's group had also developed those extracorporeal pneumatic pumps experimentally. And in 1988, I used those for a bridge to transplant procedure for the first time. And when Bücherl retired, I found an investor who bought the rights on these pumps from the university, and this became the first commercially available system in Europe, the Berlin Heart Company.
You had always been interested in pediatric heart surgery.
Yes.
Take us through the days in which you were stimulated to think about assist devices in children because of whatever confounding problems in getting donors, having children die in the list, and so on. Take us through those early days that stimulated you to do your really phenomenal work with the Berlin Heart for Infants and Children.
Yes. I think this was a very important step we made. After we had established this Berlin Heart extracorporeal pneumatic system together with the Berlin Heart Company, in 1990, we were confronted with an 8-year-old boy who had a huge non-contracting heart, cardiomyopathy with connected with previous aortic valve stenosis and coarctation. Anyway, the heart almost filled the whole chest. So we placed this child on an adult-size Berlin heart pump, which was the size we had at the time. This was done by my co-worker, Dr. Warnecke, who later on set up a very large and successful cardiac surgery center by himself in Germany. And we did a transplant afterwards, and of course this case showed us that there are no suitable pumps for children. And then I convinced this company.
And how long was this child supported before the
Oh,
heart
it was
transplant?
just, I think, a week or 2 days or 10 days, yeah. Because at that time, we did not have, let's say, to wait such long times for a heart. As a matter of fact, the patient is still alive and is doing fine. He had a retransplantation, I think, 18 years later. Yeah, so, but it's still around. So Berlin Heart Company, together with engineers that I had inherited from Büchel, still working with me, they developed a pediatric system, also for infants, like with 10 milliliter, 12 milliliter pumps, and small cannula. And this system we then started like in the early 1990s. And I think in 1996 I could give the first report on the experiences.
Tell us a little bit more about, this was so interesting to those of us who were just hearing about it in the United States, because we couldn't find a company in the United States which would be interested in spending the money for such a small number of patients. How is it that you were able to convince or work with them in Germany to build this array of small extracorporeal pumps or paracorporeal pumps?
I think in the beginning, of course, it was the enthusiasm we could induce into the company. But I must confess, and you're absolutely right, for the company, strictly speaking, pediatric pumps are not a very, very exciting business. And I had to repeatedly convince the company to continue to produce this pediatric system. Nowadays, of course, for the Berlin Heart Company of today, the pediatric system is a great success. But in the past, like in the 1990s, it had cost quite some convincing on our side to stay with it.
Tell us about the first implant in a small infant.
Oh, you know, we had some very small cases. Also, I must say our successes in the infants in the beginning were not very great. And I think for the first years we didn't have any survivors in the under 1 year old group.
This is the early 1990s.
Early, mid-1990s, yes. And of course this has become much better meanwhile because more experience. Also earlier implantation. Because as you understand, for the pediatric cardiologist to implant such a system at that time was the very last resort. And of course, they were very hesitant to accept such a system, which they thought is like a hell machine. Nowadays, of course, we set the indication earlier, before the organs are deteriorating. And also the systems themselves are better, the cannula are much better. We have apical cannula, which we did not have at the time. So quite a number of improvements have contributed to the system which as it is nowadays.
When you were going through this process that many pioneers really have had to go through, of the agony, of the pain of seeing in your mind, a desperate child who, you know, the probability of survival is very low, and well, we have a pump. And how is it dealing with your colleagues, with the nurses, with the families for those several years before you could really establish routine survival with these small pumps? Were you ever discouraged to think of, well, there won't ever be any pumps that'll work with children, or did you just have to keep persevering and reestablishing rapport with the hospital and the nurses that it's going to work, we just have to keep working? What was the atmosphere?
I think I didn't have this problem because that these pumps are working, I think this was visible for everyone. But of course they had some complications. They had bleeding, for instance. Anticoagulation with these pumps was not so, let's say, well established. But I didn't see those problems with the administration or with the, let's say, with the staff to work with those systems. It was more let's say, the decision making to start with it. which of course nowadays is a very well-established procedure. And this was not at the time. There were discussions, of course, and maybe too long waiting for in many instances. But we had some successes, of course, maybe not in the very small ones, but in the maybe 2-year-old or 3 or 4-year-old children. They were very convincing survivors to begin with. So I think it was not so difficult to stay with this concept, because it was obvious we need such a system. It has to be improved, and eventually it will be better.
Heart-lung transplantation.
Yes.
Tell us about your somewhat historical efforts there in Germany.
The first combined heart-lung transplantation, I think, was done by Bruno Reichert in Munich in, I believe, in 83 or 84. In Hannover, I had done one case which was a disaster. It was a completely wrong indication. This was a young lady with chronic pulmonary embolism and totally cyanotic and many adhesions in the chest, and it was a catastrophe.
And that would have been in what year?
This was in 1985. And then in Berlin, we started such a program for the first time in, I believe, 87. And with the 3 cases, but there were some problems in all 3 of them. So it was not so encouraging. Besides, I must say, at the time, I was so kept up with developing the entire program that I probably did not have sufficient time to concentrate on such a new program. But we started then again with isolated and bilateral lung transplantation, and then added also the heart lung transplantation. Now we have more than 100 combined heart-lung transplantation done over the years, but as you know, due to the shortage of organs, it is almost impossible to find a suitable package nowadays. And of course, also many of the cases that in the past we were considering for combined heart-lung transplantation, like those with primary pulmonary hypertension, we treat differently today. We have excellent pharmacological tools to handle those patients for a long time, very successfully, prostaglandins and so on. And what's left over are only, let's say, the absolute end-stage congenital cases, mostly. From time to time, there are cases with both end-stage lung and cardiac disease, but this has become, let's say, a rare instance. So I think combined heart and lung transplantation, although is fascinating, is not performed very often anymore. Maybe 2 cases a year at the most. So I think this was a field we at the time we thought we had to develop and include, but I think time has gone over that somehow.
As you look over your career, which you are one of those unusual people who has been involved in almost every facet of cardiac surgery. You know, there aren't so many of those anymore. And certainly people in training focus on one area or another. What gives you the greatest satisfaction of your accomplishments over the years? How do you view in your own mind your greatest contributions?
Let's say, except for individual cases that, as you know, as a cardiac surgeon, are always stay with you for a lifetime. in good and in bad. I think it's very important. I think I had the chance to view this, let's say, rise of cardiac surgery in the 1970s from a more or less experimental small field to a really large field of important medicine for large groups of patients and for all kinds of diseases. And also the establishment into a routine. And as you mentioned, of course, nowadays there are no surgeons anymore coming up that have the opportunity to independently perform all the individual or all the specialized fields and operation types and so on as I had. I think my unit as it is now, this heart center in Berlin, has one remarkable feature. It covers the entire field. There is no field in cardiac surgery that is not represented in, let's say, a highly professional and also fairly large patient groups. Like we have a very good pediatric program with 500 to 600 cases a year, with many interesting contributions. I have some very gifted young surgeons. We have, for instance, a program for premature children for open heart operations, with as small as 900 gram on open heart correction, and many other contributions. Also, we have this transplant program, which is sort of a little bit, is somewhat reduced during the last years because the number of donors in Germany has gone down overall. But it is still flourishing. And we have done altogether more than 1,700 heart transplants and roughly 400 lung transplants. And we have this very large assist device program, which is the largest in the world from numbers of implantable devices of all kinds. And in this field, of course, we had the opportunity to do quite a number of original and first-time procedures, like the first rotational pump implantation, DeBakey, 1998. Or we saw this weaning recovery of the heart in dilative cardiomyopathy and explantation of the pumps in 1995 for the first time, and several such things. And also we have a very large aortic surgery of all segments. Also we do the endovascular stent implantation for aortic aneurysm dissection in the surgical department by surgeons. There's now 900 such endoaortic grafts. Or we have now recently developed a very successful and good program for such hybrid operations like the transfemoral or transapical aortic valve implantation, with now more than 400 cases already. And on the whole, I think the fact that we have established the principle to take every patient who is offered to us, no matter how sick he is, and we then would decide what we can do best for him. This principle, which in early times, of course, was not so common in the country, where it was more common to let's say, reject patients, or when they were probably, also when the capacity of the units was not there. Yeah, I think this attitude has earned us a reputation of all over the country, all over the continent also. That means if you don't find any place, you still can send the patient to Berlin.
And when you think specifically of mechanical support, with all of the known limitations of donors for heart transplantation and the quite incredible explosion, particularly currently, of continuous flow pumps, what do you, as somebody who really grew up with that field, what do you see its future, let's say in the next 10 years, of the influence of pumps versus transplantation in the mix of advanced heart failure?
I think in my experience, or our experience in Europe, or Central Europe, heart transplantation, although it's a fascinating field and with very good results, and also at long term, is not something we can build supply on. We cannot supply the population that needs heart transplantation with this procedure. That means I call it a casuistic procedure. You know, it's only good for the patient who has the luck to be listed at the right unit at the right time, and he is lucky enough to live when an organ is available just for him. And this is there's nothing you can build a reasonable therapeutic program on. This is why I believe, and I'm very convinced, that mechanical devices, as we have today, which are, as you said, quite different from those 20, 25 years ago, will be the only tool for the next 5 or 10 years to fill this gap. And this is also our attitude. See, last year, for instance, we have implanted more than 160 such devices. And we have done 40 or 45 heart transplants. This discrepancy also shows that this is not something which substitutes the other. It's additional. Also, many of the patients where we implant nowadays assist devices would not qualify for heart transplantation anyway, according to our criteria, for various reasons. High pulmonary vascular resistance, age, associated organ failure, and whatsoever. So I think, of course, we go on with the transplantation, especially for children and young people. And for those, in general, also we get organs when we wait long enough, or when they are on assist devices as a bridge. But the larger number of patients now receive an assist device for permanent to begin with. And we have now patients over 80 years old, 83 years old. Of course, in this higher age group, you have to certainly employ selection criteria in order to not to make this field questionable or unethical. But there are, of course, elderly people who have a clear mind and a sharp intellect, and who are willing to live, and also are intellectually capable of dealing with such a device. And I don't see any reason why to deny them such an opportunity to live for another couple of years, which in fact they do. So I believe this has to be separated. It's not a competing field. It's not a completely, let's say, overlapping or congruent field as it was in times of bridge to transplant. But it's something which is more reasonable and according to the need of the patient, and additional. That's how I would term it. But in the coming years, I'm very convinced that we will see many, many more of such cases with small, quiet, silent pumps, easy to handle, less complications, less thromboembolism. So I believe it will be a standard therapy for heart failure.
Great. Thank you very much.
Thank you.